So the topic of my presentation today is invasive oral procedure treatment concept in patients treated with Prolia. If we look at the PubMed under the subject dental implants in patients treated with Prolia, one can see that in the last 10 years not so many publications exist. Nevertheless, in the last 2 or 3 years we gain more interest under this subject. I would like to give a short introduction on Prolia. Prolia, which actually the name is denosumab, is a human monoclonal antibody that inhibits bone resorption. It's not like the biphosphonate, but still has the same effect on the bone rehabilitation, bone resorption. Its impact on dental treatment, though, merits further investigation. Despite its benefits, Prolia possessed challenges in dental procedures due to its effect on bone metabolism. What are the indications for Prolia's treatment? Osteoporosis is one of the main indications for treating patients with Prolia. Secondary bone tumors, bone metastasis like breast cancer and even prostate cancer, multiple myeloma. Multiple myeloma, it's according to some physicians, Prolia is not recommended. Yet in the literature you will find recommendation to treat multiple myeloma with Prolia as well. There are some disadvantages of Prolia treatment for dental treatment. The first is the risk of medication-related osteonecrosis of the jaw, like what we call meronge, due to suppressed bone turnover. This is very similar to the bisphosphonate reaction. The second risk and disadvantage is a risk of inadequate osseointegration, delayed healing, and compromised bone quality. We continue with the disadvantages of Prolia, not just for dental treatment, but in general. Following discontinuation of Prolia treatment, and this is very important, there is a rebound effect for fracture increasing in the vertebra and in the bones. So this is very dangerous. When you stop Prolia, you get this rebound effect. And the second disadvantage, Prolia does not bind into hydroxyapatite and incorporate into bone. Thus, bone cellular remodeling recovers rapidly after drug suspension. Well, one may think this is not exactly disadvantage, yet each time you give up the administration of Prolia, this rebound effect pump out and make it dangerous for the patients not to take Prolia right in time. Nevertheless, we can turn this disadvantage to advantage for dental treatment. If we look in this graph of Prolia administration and the amount of Prolia in the blood, one can see here in this graph that this is the injection time, the 0, and then in the second and third months we have a rapid decrease in the amount of Prolia in the blood, and then you get another injection 6 months later. Again, this ritual happens every 6 months. So how do we overcome the challenge of Prolia? Due to the profile of the Prolia, the decrease in the amount of Prolia in the blood, the time interval in which invasive oral treatment can ideally take place without restriction in patients with metabolic bone fragility. So this is a challenge and a benefit over the treatment with bisphosphonate. Yet, preoperative assessment is very important, comprehensive evaluation of the patients. Serum mark CTX is optional. Since we know this ritual of the Prolia, I actually do not use any more CTX examination prior to the invasive dental treatment that I perform in patients who get Prolia as a treatment. Adjusting the timeline to mitigate the effects of Prolia is very important, and use also PRP and bone grafts is recommended. Close monitoring and collaboration with the physician, with the endocrinologist, is also very important. This is actually the heart of this presentation, timeline of patient treated with Prolia. So the 0 time, as we saw, is here, the injection. And then somewhere here we evaluate the patients. The patient comes to your office and you need to examine him. You can decide to perform CTX at the decreased time of the Prolia, and at 4.5 or 5 months we know that we hardly have Prolia anymore, and this is the window time that we can perform our treatment safely. Delayed dosing window is also possible when you communicate with a physician, with the endocrinologist. You can take sometimes more than a month and make the injections, the next injection, at 6 or 6.5 months, and sometimes 7 months, but this must be under control. So the surgical procedure will be performed a month prior to the next injection of Prolia, and then we will do the post-op evaluation, injection of Prolia at 6 or 6.5 months after the previous injection, and then long-term follow-up. So this is actually the timeline for patient treated with Prolia in invasive intervention in dental procedures. And now I would like to present 4 short cases just to show you how I treat patients, of course who are treated with Prolia, and yet I treat them as regular patients, almost. So let's take the first case, immediate implant placement and immediate rehabilitation, temporarization. It was a female patient, 73 years old. Preliminary evaluation diagnosis was osteoporosis for 15 years, yet she was treated with Prolia the last 4 years. If you look at that intraoral view, one can see here the broken central incisor, the left upper central incisor, and on the right you can see that this is a root that, according to the dentist, untreatable. So if I put here the timeline, now at 5 months, this is the time for the surgical procedure. So the surgical procedure is a regular surgical procedure, atraumatic extraction, immediate implantation. You can see here the implants inserted. This is a temporary abutment, augmentation with xenograft material saturated in PRF, and then immediate provisionalization by the prosthodontist. This was by Dr. Sivan Shocher. Few months later, a fixed rehabilitation, and this is already 4 years post-op. 4 years post-op. This is regular and normal result in such cases. So let's see the second patient. The second patient was much more challenging, as this was a female, 79 years old, yet she came as emergency treatment. Emergency treatment sent by her endocrinologist. And why she was sent? Because she has acute abscess from a broken molar, mandibular left molar, yet she got the last injection few days earlier to her admission. And I was really concerned about it. Here you can see the intraoral view. Oral hygiene was terrible, and if you look closer to the area, one can see here the infected tooth and the fracture part here. So after communicating with her physician, we have decided that she will get just emergency treatment. At time of administration, this is just few days after the Prolia injection, because we have assumed that it will be much more risky to wait 5 months with such an acute infection. So under the IV antibiotics, so cefazolin and a flagyl of 500 milligrams, I extract only the fracture slice. And here you can see before and after 5 months. So I gave her antibiotic followed by per-os antibiotics for 3 weeks, and then we waited 5 months, and here you can see it after 5 months. And then, only then, I could extract both the first and second molar, mandibular molar, and you can see here's the timeline. Now it's 5 months after the injection, and we can perform regular treatment. So at time of the operation, extraction was performed. I try not to raise huge flaps. Actually, it's flapless like the previous patients. Implants are placed after thorough curettage of the infection. Healing abutment are adjusted. Augmentation with xenograft material saturated in PRF, and then I cover it with PRF and suturing with Vicryl resorbable suture. So this is regular, immediate implants placement in molars, mandibular molars. And this is immediately after operation. And healing was uneventful. The third patient, 69 years old, preliminary evaluation was osteoporosis for 5 years, and she was treated 2 years with Prolia. In this case, one can see here the intraoral view, yet when you look at the panoramic view, you raise a huge question mark. How come a patient was treated with Prolia without dental examination? And this is very important because we know that usually before treating with bisphosphonate or Prolia, one must examine the dental condition, and this was not performed for this patient. And you can see here the huge infection in both implants. So I've decided at the same timeline to remove these 2 implants, to leave 2 implants, just not to lose all the bone here, at a time of implant removal, to perform ridge preservation, and after a while to add another implant or to remove the ailing implant. And here you see 1 implant removed and the second implant removed. You can see the infection. Luckily, she didn't got bone necrosis due to this infection. Curettage of the granulation tissue, thorough cleaning, and then with water peroxidase and chlorhexidine 0.5%, rinsing with sterile water, and then augmentation with xenograft material saturated in PRP covered with PPP and resorbable membrane, collagen membrane. PPP is platelet poor plasma, and then suturing. So this is immediately after operation and 5 months later. So one can see here the healing was uneventful. This is like in regular patients. And this is already a time of removal of the third implant and placing another implant at the area of the first premolar. So the remaining infection or connective tissue was removed, implant was removed, here you can see the implant, new implants placed at the position of the first premolar. One can see here the bone. Look at the bone. This is a vital bone. This is actually the bone that was placed 5 months earlier at time of implant removal, and then connective tissue graft is done. I remove the epithelium. I suture it after releasing incision of the periosteum to the buccal side of the flap, releasing incision blunt in the lingual aspect. I perform augmentation with xenograft material and PRP, platelets-rich plasma, covered again with PPP, platelets-poor plasma, and resorbable membrane for guided bone regeneration. This is suturing the connective tissue graft and closure. And this is immediately after operation. So actually, I perform operation like regularly. At this time, 5 months after injection, I just act normally in these invasive procedures. So here you can see this patient. This is a very challenging situation, and of course we should prevent this condition prior to administration of bisphosphonates or Prolia treatment. Bone augmentation performed at 5 months after the Prolia injection, immediately after, and 5 months post-op. The last case is a case of sinus augmentation procedure with implants placement simultaneously. 70-year-old patients suffer also from osteoporosis for the last 15 years and the treatment of Prolia for the last 5 years. I just show you the operation, extraction of the first molar. I do it through the sinus elevation technique. For her, I perform through lateral window, and one can see here perforation of the Schneiderian membrane. I correct the Schneiderian membrane later. This is extraction of the tooth, and here you can see the preparation of the suturing of the Schneiderian membrane with resorbable suture. And then I perform the implantation. I use the PPP, patient's own plasma, to further correct the Schneiderian membrane, fill the cavity with xenograft material saturated in PRP, and then implants are placed, more bone is placed, and cover the defect with its own window, cover it all with PPP, platelets-poor plasma, buccal fat pedicle graft, who gives us lots of vascularization, volume, and protection. I do it in many cases of at the posterior maxillary augmentations procedure. I use the buccal pedicle graft mostly for vascularization, but it gives also the protection and volume. And this is prior to operation and 3 years later. I would like to conclude this presentation. We presented a realistic treatment timeline to reduce the risk of necrosis due to the use of Prolia in individuals with osteoporosis during Prolia treatment. Thank you very much.